Good afternoon. I'm Colin Pearson. I'm a Regional Care Development Advisor for the Motor Neurone Disease Association. It's awesome to be here this afternoon, all you enthusiastic professionals, so hello. I'm here today not just to represent myself, and the association, but that's already gone. This team of people here, they're all involved in a project at Butterwick Hospice in Stockton. Stockton you might never have heard about. Well, actually you might have. It's quite famous for the railway, Stockton-Darlington Railway. Otherwise you probably won't have heard about it. But they were a pioneer in the railway and also in this project that we've developed here. So today I'm talking about the anticipatory approach to palliative care that we've developed. Of course, palliative care is the active, holistic care of patients with advanced progressive illness, the management of symptoms, provision of psychological, social, and spiritual support. The goal, of course, is achieving the best quality of life for patients and families. So that's, of course, what we're trying to do. It was found locally that a particular group of patients weren't able to access our hospice and palliative care services due to eligibility and misconceptions. Support services that were accessed as symptoms developed, but that was often reactive and not proactive. And there were various barriers to patients engaging, resulting in decreased early monitoring, anticipatory support, involvement in support and uptake of services. So Anthony Hanratty, our dear MND Care Centre coordinator at Middlesbrough Care Centre, who's over there today, thankfully, we undertook a listening exercise 2 or 3 years ago now. And we were told by patients and people living with MND that they had limited or no access to mainstream or traditional palliative care services. They were frightened at meeting others at a more advanced stage of MND than themselves, the dreaded fear factor that we hear so many times. People recently diagnosed were usually still maintaining their independence, in fact, usually fighting to maintain their independence. They were working, socially active, and therefore, if they did want to join in with networks, it was difficult for them to give up that time in the day, full-time or half-days, to access those networks. And often they had multiple psychological, physical, emotional and social needs that had not been addressed by professionals. And that's not a criticism, but we know that often things are taken up by being reactive to problems rather than getting to do all the forward planning that we really would like to do. And if I move my slide on, it helps. There we are. So this group of individuals also did not have complex needs. They were newly diagnosed. They were being managed in the community by community teams, and hospices and palliative care services deemed them too unwell, too stable, and therefore they did not meet the criteria and were unable to access support. Funding for hospices in England is restricted by geographical areas, so towns or districts, due to the fundraising etiquette, and hospices really don't cross over into each other's boundaries. Therefore, individuals couldn't cross over those boundaries to other services. Small numbers of patients and people living with MND in areas meant that any MND-specific services and service developments were usually unfeasible. There remained a general public perception myth that hospices and palliative care services were accessed by those at the end of life, and accepting support would indicate you were going to die. Again, that fear factor. Due to the high demand on services, there was no scope or funding and space restrictions within hospice services, so that was patient places, to develop new services or indeed service trials. So models of care often remain strictly traditional. So we had to come up for solving a problem, And Anthony and I are usually quite creative in the way that we try and do that. So we set about in one of our usual meetings of developing a collaborative project. So we had there the Middlesbrough MND Care Centre, the MNDA RCDA, that's me, the MNDA Cleveland branch, so that's our local volunteers, and also Butterwick Hospice. And we were having a conversation one day, and the hospice announced that unusually they had small numbers of patients and had some spare capacity. So immediately Anthony and my ears pricked up and thought, okay, maybe we can do something there. So we had some talks with them. And of course, not wanting to be too pushy, because that's not the way we do it in Middlesbrough, we said to them, well, how about a neurological service? And we got Parkinson's UK involved too, because we really thought we wouldn't get anybody with MND participating anyway, but we wanted to give it a shot. Well, little did we know. So the objectives were, obviously, we wanted people to access hospice, palliative care, and nursing services. We had to be creative. How are we going to get people through those doors? Because obviously they were frightened. So we came up with the concept of complementary therapies. Now, different people think different things to complementary therapies, but we thought, okay, we'll give it a go. It's something that people might take up. It really might be useful, and it would get people through in a non-threatening way. We also wanted additional MND nurse support, so additional advice and monitoring, as Anthony usually only sees people every 3 months in the regular clinic appointments. We wanted more links into the MND Association, local branch and our association visitors. We wanted to get people into those networks earlier. And also we wanted to link and transition people to their local hospices and palliative care services. So once they were in through the door, we wanted to work on getting them out of the door at the appropriate time to the appropriate services. Key performance indicators. Well, we didn't want anything too unwieldy, so we picked 3. We wanted to facilitate early access to those services, and that's quite easy to get indicators and numbers about that because we had the people potentially coming through the door. Equally, with complementary therapies, we would be able to monitor and assess the number of people undertaking therapies. And improving quality of life, well, obviously it's easy to get that from patient feedback. So what is the service? Well, the service was initially a drop-in session, again, non-threatening, get through the door, come in, have your therapy, leave, and pretend you've never been there. That was the idea. Complementary therapy sessions, obviously, that was the tool to getting them in. We would have a social element because that was there in the hospice environment, but of course we wouldn't want traditional daycare because people don't do traditional daycare. And also what we wanted was peer support and self-management, people helping themselves, those people talking to each other, supporting each other. And of course, the hospice said we could have their hospice nurse who runs the daycare for our session. Anthony was creative in the criteria. We had to again be creative about that. So it was not attending other hospice services locally, able to come and access independently, mobilize independently, and that did not require support with personal care. We felt awful having a criteria because obviously, you don't want to say to people, you've got to go now, but we told ourselves, well, it's moving people onto the appropriate services and support. So that's how we justified it to ourselves. The clinical outcomes, well, the patients reported positive impact upon their physical symptoms, including reduced GP and community nursing visits. So they were getting that support. They were talking to Kath, the daycare sister. They were having those conversations and not needing to run to their GPs. Kath, in turn, she gets in touch with Anthony, so there's a network of support there for them. They wanted more and more complementary therapies. We just couldn't provide enough. Indeed, the afternoon session wasn't enough, so we had to start taking up the whole day. Fortunately, no people with Parkinson's ever came, so we were okay with that. So we've got the whole day for ourselves. And improved psychological well-being. People felt empowered, increased confidence, greater independence through peer support. and feeling supported by the professionals. They felt linked into that support. Now, we didn't initially set out the pilot to look at carers, not that we didn't want to look at them, but just because of the numbers. However, they also felt supported too, and they did start coming, and they felt more confident in their ability as a carer. And also being able to access support in a more timely manner, knowing the availability of local services. Now, patient feedback. This picture is it causes a tear in my eye too, because this young gentleman there, Michael, I got to know Michael basically when I started working for the association. And this guy is my age, we're the same age. And so it's always hard-hitting, isn't it, for any of us when we meet people with MND, but particularly when you meet somebody across the room living with MND who's actually the same age as you. It really brings that home. This is Michael's 40th birthday there, actually. And the hospice and all his friends at the hospice within that session, they put on a birthday party for him. And actually one of the really great things was, it's not always about medical interventions. Sometimes it can be just those little things. And through those conversations, they discovered at the hospice that Michael had a love for astronomy. He loved looking through his telescope. Now, he couldn't do that anymore because he lost the function in his hands and arms, so they managed to find equipment to adapt that so he could do that. Anyway, the MNDA in the Cleveland branch actually bought him a star. Obviously, you can do these things these days. So somewhere out there in the world, there's a Michael Hogarth star. And again, that's a legacy for Michael, for his family. So whatever happens, that being of Michael is always there. And I think that's one of the real good things about our project. What did people say about it? Friday afternoons make the following week seem so much more bearable. Butterwick is a safe place with staff who care, where you're not just a number, but a person that matters. Butterwick beats any pill or magic potion. Butterwick gives us support without pity. Some quite amazing quotes there, and obviously that's just some of them. So the recommendations, really, to give to you is, obviously, the concept and what we did is transferable to other hospices and other services. Be creative yourselves wherever you are around the world. Look for innovative ways to increase earlier patient engagement. Patients and carers obviously report feeling more empowered, confident about living with MND. And other hospices in our area have recognised the benefit and impact of this service for the patient group. So 2 other hospices have taken up this pilot. As I say, we've also rolled out to the morning and not just the afternoon. And another hospice up in Newcastle is also looking at trialling a similar project. So really, it has a whole holistic approach, really, that can be tried anywhere. And I would stress to you, just give it a go. If you've got somewhere locally where you can try something similar, please do so. And while there's questions, there's just one of those Wordle things these days that seem to be the in thing. But that's some of the comments from the people at Butterwick Project and what they've said about the support that they get. So thank you very much.
Thank you, Colin. There's certainly time for questions now.
Rod Harris, Motor Neurone Disease Victoria. Colin, congratulations.
Thank you.
There is no doubt that early access to palliative care in the environment reduces fear, it improves take-up of palliative care services, and the sooner we can get palliative care to stop talking about death and end of life and start shouting about quality of life with palliative care, the better off we'll be. So well done. Congratulations.
Thank you very much. Thank you.
Anyone else?
Thank you. John Costello, Boston. I'm curious because, and I know that health services vary dramatically from region to region, country to country. So I'm curious, in the UK, when one is engaged with palliative care or a hospice, is there any impact on other services? And the root of my question is in the United States, as soon as one becomes affiliated with hospice or palliative care, there is no more access to a number of other services provided through insurance, including any kind of durable medical equipment, wheelchairs, speech-generating devices, et cetera. And so there's a disincentive to get involved earlier, despite there being clearly, and you've highlighted it so incredibly well, such value to being early involvement.
I think we're fortunate probably in the UK that we don't have that problem, that, you know, once you get into, obviously hospices aren't statutorily funded, so that's not really an issue. They're given charitable organisations, so, you know, you can access statutory services and hospice services too. So we don't have that problem. I suppose the concept in itself is, it's about how you promote that service. So I suppose in America you might be able to call it something else. So I suppose what we're really looking at is that support network. So obviously, because we want to, as an association, and knowing that that's good care for people with MND, we want to get them into palliative care services. However, you might have to be creative in calling your service something else and having the same aims, but not making that fact particularly known so that the insurance companies aren't jumping on what's happening. And to be fair, we have had a similar problem in one of our hospices locally. They have daycare service, and as I said, people move to their local hospices. Now they only have a 6-week rolling program within that local hospices, and we're having at the moment this problem where patients are eligible to transfer to the appropriate hospice. However, if they did, after that 6 weeks, they would be stopped from using those services. So we're actually having some interesting conversations with people living with MND around, well, actually, you might be better in this service for as long as possible before you actually move over to the appropriate service. But that said, they're linked in the appropriate network of support, and I think it's that we're trying to do ultimately.
Okay.
Thank you.
There's other questions?
Hello, I'm Rachel Marsden from Oxford, and actually you sort of answered my question in the last question, but it was really, I understand the criteria you set was kind of fairly challenging, I should imagine, but did you have any problems with the transition to moving on to the next service?
Oh yes, we've had massive problems. The patients and people living with MND that attend the service, they don't want to go. If they go to a different service, it's not as good as Butterwick. Part of that is the peer support, the social network that they experience there. So there's a large number of people with MND, and when they move across to traditional services, obviously they're one of a person with MND, and so that's something that's really interesting, that they don't want to do that. So again, it's linking how we link them in then locally to the other support networks, such as the MND Association, support groups and things like that, so they're still linked in with their peers. And interestingly enough, we didn't have a get-out clause at the end when Anthony and I developed this project. And so in Hull, where we've developed a similar project, that's one of the things that we did straight away, was have a rolling program, so every person was evaluated every 8 weeks as to whether it was appropriate they were still there. So it's clearer from the beginning. So yeah, that was some steep learning, I think, that we had over at Butterwick.
There's 2 questions.
Oh, thank you. Christina Dodds from Sydney, over here.
Sorry, the lights are really good.
Just wondering what the complementary therapies were that you induced people to come along to palliative care with.
Yeah, so there's, now I've got that written down, but it's aromatherapy, I think massage, Reiki, and relaxation therapy. And actually, the complementary therapists at Butterwick, they've actually won an award. You might have read it in some journal of complementary therapy, where they actually won an award for this service and using complementary therapies in such a way. And they've had such a positive, experience for those people. And I mean, I shouldn't really say this because Sally, our CEO's here, but I did sit in a relaxation therapy with Michael, who was up there, and I did fall asleep, so I can attest that it was really good. But I believe you've got to try these things out, so, I'm sure it was allowable on that occasion.
Okay, about 30 seconds. Go ahead.
So is this still a project, or is this your norm?
Yeah, so we're actually, we have come out of the pilot now, and we actually are ongoing with this project. And the pilot really was around the hospice, because they didn't know whether they could, whether it was a good use of their funds in doing this. So we had to justify that it was good use of their funds as well as our own. But yes, we're out of pilot now.
Well, thank you for doing this. This should really just be a norm of whether it's palliative care or hospice. This is real tending too. So thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.